Hello, my name's Nigel Stephens. I'm a consultant cardiologist, and I'm here to talk a little bit about echocardiography or cardiac ultrasound. So this is a powerful test that we use a lot in cardiology. It's based on a physical principle, a bit like sonar in submarines, where you send a sound wave out through the person's body. It bounces off structures within the body and returns to a sensor, and you use a computer to turn those little signals into a two-dimensional image of the thing you're looking at, in this case the heart. I guess most people are most familiar with this type of technology when a woman is pregnant. It allows you to look at the growing fetus. The other powerful thing with cardiac ultrasound is that you can look at the movement of blood. So a lot of people have probably heard of a Doppler effect, whereby the noise of a car coming towards you increases in frequency, and when the car goes past, it decreases in frequency. And you can use that same physical principle by bouncing your sound waves off the blood flowing through the heart and see what direction the blood is flowing and whether it's flowing fast or slowly, and whether it's smooth or turbulent flow. Because echocardiography has improved so much and has now arrived at a point where we can get so much detail and diagnostic information in a painless and straightforward test, it's pretty widespread, and you have a reasonable chance, if you consult a cardiologist for whatever reason, they would want to do an echocardiogram. The actual business of it is fairly straightforward. You need to undress in your top half, and the person doing it, either the doctor or the sonographer, who's a trained technician, will put a probe, maybe the size of a computer mouse, on your chest. They move the probe around the chest, and they'll ask you to take up different positions lying on the couch so that they can get different views of the heart. Sometimes, particularly if you've got a fair amount of muscle or fat between the probe and the heart, they have to press quite hard. So you do sometimes need to grit your teeth a little bit if we want to get really good pictures. The whole thing will take about 20 minutes. And one of the slightly annoying things, if you're having it done, is that you're facing away from the TV screen that's showing the image. So when you've had it done, you need to speak nicely to the person who did it, and they may show you the highlights from the scan itself. 20 minutes of scanning gives us all the standard views, as we would call them, of the heart. The information is widespread and valuable. To give some common examples, we can see whether the heart is pumping strongly or damaged or malfunctioning, in other words, whether the person has heart failure. We can see whether the 4 heart valves open and close normally, or whether they're restricted in their opening or leaking. We can see whether the person has been born with any heart defects. Above and beyond these, what you might call straightforward measures, we have a range of more specialist heart ultrasound techniques that we can also employ. So one example of this is transesophageal echocardiography, or TOE, as it's often abbreviated. So here we use a device which is quite similar to the gastroscope if you're having somebody look for a stomach ulcer, only in this occasion you swallow the ultrasound probe and it looks at the heart from the back rather than the front. The power of this is that we get much higher quality images because they're not interrupted by lung tissue or anything else that's in the way, and also we can see all the parts that are at the back of the heart. And a good example of why we might do a TOE is if a person has had a stroke, which hasn't been explained by any other test. And here we can look for blood clots or other abnormalities in the back part of the heart to see if they were responsible for the stroke. A TOE is nearly always done with sedation and with a local anaesthetic spray in the throat, and again would take about 20 minutes and is done in a 3 or 4 hour hospital visit to allow recovery from the sedation. The other thing that we increasingly do is what's called exercise stress echocardiography. So here we use a combination of treadmill exercise and ultrasound to work out if a person has narrowed or blocked arteries. So a typical scenario might be a person has angina pain or unexplained breathlessness. You scan the heart at rest, you get the person to do a ramp protocol on a treadmill, so they're walking uphill steeply and more quickly. And then you scan the heart when it's working very hard in the immediate aftermath. And this allows you to see whether parts of the heart are working normally at rest, but abnormally once we stress the heart. And this, if it's done well with good technology and good expertise, has at least a 90% accuracy in diagnosing whether that person's symptoms are due to narrowed or blocked arteries. We also have some other more niche and specialized applications. In people who have unexplained strokes, we can do what's called a bubble study, which allows us to determine whether there's a small abnormal communication between the left side of the heart and the right side of the heart, or vice versa, and whether that small hole in the heart has caused that person's stroke. And it's important to do, particularly in younger people with unexplained strokes, because we can close the hole and thereby prevent future strokes.